Hello, my name is Dr. Asley. I'm a board-certified fellowship-trained spine surgeon, and I'm the medical director here in Sacramento Spine Treatment Center. In this segment, I'll be discussing with you a surgery called disc replacement surgery. It's a surgery that's performed for continued neck or low back pain for a condition called degenerative disc disease. Now, before we go any further, I need to tell you what I feel about that name, degenerative disc disease. Now, when the spine surgery was very young, in early 50s and 60s, with the studies that we had was x-rays. We could see back and see the disc, the cushions between the bones have deteriorated and causing bone rubbing on bone and causing continued neck and low back pain. Therefore, it was called degenerative disc disease. Now, throughout the last few years, we've had an immense amount of research and studies like MRI that we are actually able to see the disc itself and follow it throughout the years. Now we realize that majority of these discs, they go bad because of a history of trauma. That means the patient sustained a problem, an injury, either for their neck or low back pain, which violated the integrity of this disc, therefore causing it to go bad within the next few years and causing significant neck and low back pain. Therefore, the more appropriate name for this problem should be damaged disc disease as opposed to degenerative disc disease. Now, there is a subpopulation of people who are suffering from truly a degenerative disc disease. These are the people that they have a collagen, a substructure of the disc that is weaker than the regular population. These people probably have relatives that are suffering from neck or low back pain. And if you look at their MRIs, not just one disc, but they have multiple discs that are not looking good. That subpopulation I can understand calling them they're suffering from degenerative disc disease. But majority of people that I treat are suffering from damaged disc disease. Now, when a patient comes to see us for continued neck or low back pain, we'll do whatever we can to avoid surgical intervention. We'll try physical therapy, epidural injection, traction decompressive treatments, acupuncture, whatever we can to avoid that. If you do those and the patient continues a significant amount of pain and patient decides that they want to proceed with surgery and we have a solid evidence that shows us a particular disc is causing the problem, then patient is a candidate for the surgery. In the past, the surgery that we had was fusion. Take the disc out and turn the two bones into one bone. Now, with a disc replacement, we can actually preserve the motion and not fuse the bones together. It could be done in the cervical spine or the lumbar spine. The way it's done in the cervical spine, you make the incision about this long right here, push the esophagus and trachea to the side, and you're looking down the spine, and you take the disc out and put the prosthesis in the, between the two bones. Now, this is an example of a anterior lumbar fusion. In this, we have taken the disc out and put a solid prosthesis in there. And in this surgery, the bone grows between the bone above and below through the middle of the prosthesis, and these two bones will turn into one bone. However, in this example, you can see that we have taken the disc out and have put this prosthesis in here, which allows motion between the two bones. Now, there are a few problems with these prostheses. Disc has two functions. One is motion, two, restriction of motion, stability to the spine. These prostheses replace one function, which is motion, however, do not give any stability. That means that function of the disc, the stability, now gets transferred to the facet joints, these gliding joints in the back. Or if they don't get the stress gets transferred to the bone-metal interface between the prosthesis and the bone. So what happens throughout the years, either the facet joints become arthritic or the prosthesis get hammered into the bone and you get settling of the prosthesis. That's one thing. The other factor is human anatomy. The lumbar spine, you have vena cava that travels in front of it, drains the blood from the lower extremities into the heart. Very big vein, has a very thin wall. When you do the surgery, it scars down. And if there's something wrong with that disc, there's no way back. There's no way we can go back and move it out of the way. If we try that, it will rip, which would be very devastating. Therefore, because of the vena cava, the disc replacement in the lumbar spine is a one-way street. In the cervical spine, however, is different because you have esophagus in front of it. It's the tubular structure, muscular, which is very thick, and it doesn't scar to the spine. Therefore, if that disc replacement fails, we have a chance of going back, taking it out, and turning it into a fusion surgery. The other thing is amount of force transmission. In the cervical spine, as opposed to lumbar spine, the force transmission is a lot less because all you have is the head. In the lumbar spine, even though the vertebrae is bigger, but you're talking about carrying the entire torso, upper extremity and torso. Therefore, the pressures that are getting transmitted in the lumbar spine are a lot more. Therefore, chance of settling is a lot more. Therefore, in Sacramento Spine Treatment Center, we do endorse the cervical disc replacement, and we do perform that, and we do believe in it, especially in some subpopulation of patients that are young, in their late 20s or early 30s. It's a God-given gift. We really didn't have a good answer for those people because they were too young for fusion, and they were suffering from this pain, neck pain, which didn't respond to non-operative care. For that subpopulation, is a God-given gift. However, in the lumbar spine, we are very cautious, and at this point, based on the research that's coming out, which is basically they're telling us that the disc replacement is not doing what it's supposed to do, which is stopping the progression of the problem on a disc adjacent disc, is not doing that. And the pain relief is not any better than fusion. Therefore, at this time, we are very cautious about lumbar disc replacement, and we do not endorse it at this time because simply we just don't have enough information and research. I hope you enjoyed this segment. Have a nice day.